Thank you all for joining us today for our webinar, Navigating Telemedicine Tips and Tricks. This is a special webinar as it is the kickoff for our Keto University series of webinars. For those of you that are new to Keto University is typically a live 3-day program that we offer to approximately 40 to 50 healthcare professionals in the US and Canada. It is a program that is led by our Keto ambassadors who will be speaking for us today. Given the circumstances, they have graciously helped us transform our 3-day program into a series of webinars that we will be holding over the next 3 months. I cannot thank them enough for being so flexible in helping us to adapt this event into something that we are now able to bring to so many of you throughout the world. So thank you to our Keto ambassadors, and thank you all of us for joining us today. And without further ado, I would like to introduce all of you to our Keto ambassadors. Vanessa Aldaz is a registered dietitian who has her master's degree in public health. She is a dietitian at a large ketogenic program in San Diego, California. She has more than 15 years of experience as a dietitian, and her specialty is the MCT oil ketogenic diet, in which she has provided numerous lectures and also written some papers. Lindsay Thompson is a dietitian that joins us from a large ketogenic center in Kansas City, Missouri. She just finished her PhD in medical nutrition science, in which her research focused on nutritional status, efficacy, and outcomes in patients with refractory epilepsy who were treated with the ketogenic diet. She has also written numerous papers and been on publications about the ketogenic diet as well. We will also have Zahava Turner speaking for us, who is a dietitian from a large ketogenic center in Baltimore, Maryland, where they focus on the classic ketogenic diet. She has more than 15 years of experience with the ketogenic diet and, again, many publications on this subject. As you can tell, our Keto ambassadors enjoy doing a lot of research on this subject. Our last 2 ambassadors are Stacy Bissoni. She is a dietitian from a large keto center in Tampa, Florida. She has more than 20 years of experience as a dietitian and almost 10 years of experience with the modified Atkins diet in Florida. She has written some papers and lectures on GLUT1 as well as the modified Atkins diet. Robin Blackford is our last Keto ambassador, and she is a keto dietitian from the largest keto center in Chicago, Illinois. She has more than 15 years of experience as a keto dietitian. And she, like all of our ambassadors, has multiple publications and is one of the co-authors on the consensus paper. Now I'd like to talk about some of our housekeeping items. All of your phone lines are muted, so if you have any questions, please put them in the Q&A box on the bottom right-hand corner of your screen. At the close of our webinar, we will be having a Q&A session in which we will go through all of these questions and have our ambassadors answer them. If you are unable to download a copy of the handouts at the beginning of the webinar, we are working on sharing the file with you. And if you can't get it through either of those methods, we will have a copy of the handouts available through download on nutritialearningcenter.com for our US participants. And without further ado, I would like to pass it off to Vanessa for our first talk.
Greetings to all, and thank you for joining us today. So today I'm going to review helpful tips for telehealth visits. So we have all most likely been doing more screen calls recently, whether it be FaceTime with friends or family, or a Zoom for school or work or telehealth. Some of the areas we will touch upon today, you might have already encountered yourself. So we're going to go over some tips to make a more productive and easier telehealth experience for our patients and ourselves. So some are quick legal points that are designed to protect you and your institution and, of course, the patient. But first, before I go on, it's important to distinguish between a telephone-only telehealth visit versus a telephone with photos versus a video face call. If it's a telephone only, there's a loss of the facial expression to let the patient know that you are listening. A telephone call with photos, a patient may send you particular photos to be reviewed while they're on the call. So both of these calls, it's important to use verbal affirmations to Allow the patient to know that you are listening, such as saying frequently, yes, I see, or I know, or yes, as you were saying, and short summaries to reassure the patient that you are listening. Now, a video visit may take care of these limitations. However, before you start, make sure you first obtain consent for the televideo visit, as it is legally necessary, at least here in the United States. Make sure that you have document in your note clearly if a face-to-face visit was offered or if it is available, but always document a consent. And include a disclosure if the telehealth visit was done due to the COVID-19 concerns. If photos are used, document again that you reviewed them and discussed with the patient or family whether it was a food label or a picture of a ketone strip. And also avoid sharing your personal phone number for text or of any of these photos. And again, be clear and maintain patient privacy laws and be HIPAA compliant. So you want to make sure that you dress accordingly. If you are doing a video appointment, you dress professional to whatever your organization standards are. Make sure that you are using a platform that is HIPAA compliant, that your internet connection is working so that there are no blips. It's also helpful to wear vivid colors or a color that complements you, and avoid colors that may dull you out, because you don't want to appear as a dark shadow. So consider your view and your patient's view, and have good lighting so you don't appear, again, as that shadow. So sometimes a soft light next to your camera or monitor can also help. So it's very important. So check camera angles, very important. So sometimes having dual monitors or a gooseneck camera helps. Looking into the camera and alert the patient that you may be documenting or while you're speaking to them, or where you will be frequently seeing them. So you might have them on the corner you might see them on the corner of your screen, but you may not be looking directly at the camera. So sometimes looking at the camera can also help. Sound check. So make sure your audio is clear. Avoid rooms that echo or those with a lot of outside noise or distractions. Speak clearly. Check your microphone and volume. Again, you want to avoid cell phones or beepers or anything that alarms or beeps while you're doing your visit. Candid camera. Okay. So consider your field of view. Remember, you're on camera. So be aware of those candid shots. Have eye contact as much as you can with the family. Remember, just looking at the camera every once in a while. Be conscious of any unintended gestures or facial expressions or any unintended angles, especially if you're wearing a low-cut shirt that might give viewers an angle that you weren't intending while you're taking notes or charting. Next, be mindful of your time. So still give time to build rapport, especially for new patients to you. You can allow small talk, but try not to make appointments longer than they need to. I have found that while doing telehealth, for some reason, if I'm well prepared, the appointment seems to run a little faster than when I have them face to face. So building rapport, is important. Either keeping a little timer next to you to make sure that you are running on time. Also, have a list of questions or points to cover during your visit so that you are running smoothly on time. Also, have any education material ready, whether it's sending this material to the family beforehand, whether it be via email or your organization's electronic chart email, or if the family was able to come and personally pick it up to the clinic beforehand, but make sure that they have all of those materials, especially if you are going to be reviewing those during your video visit. Also very important to, and a limiting factor is if you're doing a telehealth visit, you may not have the anthropometrics from that moment. So taking those anthropometrics from home using home scales, or if in the chart you do have a recent height and weight, you can definitely take that. But if you are depending on measurements from a home scale, this may affect accuracy. So what I have found helpful is getting a few measurements from those home scales, whether it be the week before their visit, the day of your visit, and perhaps a week following the visit. Next, you want to make sure you visually see the patient. So do a nutrition-focused physical exam. Make sure you assess the patient visually for skin, eyes, lips, hair, or anything pertinent to your visit. Also for a look on their nutrition status. I've already made the mistake at the beginning of my telehealth visits where we get distracted and the family may not even show me the patient. So that's one error to not continue to do. And also remember, if they are visually seeing you, be careful of any background, any other HIPAA information that may be going on in your background to allow for anything that is not intended to be shared with that patient. And again, make sure you clearly document everything you reviewed as best as you can. And I hope these small, simple tips help you make a successful telehealth visit.
So I just wanted to share with everybody what was successful in our first ever telemedicine ketogenic diet admission via Zoom and how that worked. And hopefully this could help you. So I am a consultant. Okay. So Dr. Kossoff somehow saw the writing on the wall. And about 2 weeks before Maryland went into a stay-at-home, or even before that, he's like, let's be prepared to have to do a keto admission from home. So we quickly prepared our binders, our whole teaching packet, our book. We have a DVD on all the classes that we give in the hospital. We prepared vitamins, keto sticks, and a scale, thanks to Nutricia, in different bags. And we came up with a whole plan of how it's going to work. We had a couple of patients that were actually scheduled for an admission week, and that was the week that we were not able to do any more elective admissions, so they all had to be canceled. So 2 of the families were actually fairly stable, so we decided to wait, and we only did telemedicine with 1 patient that was actually had started a new medication, but it wasn't working. So we made up a thing that we'd have to meet someplace essential, either a grocery store, but in the end we met at Hopkins. And they came and they picked up this bag of goodies that had everything in it. With that, I also shared with them a shopping list beforehand of what to get. And this was also, you know, I think during the very height where a lot of foods were missing from the shelves. So I really tried to, you know, this was just an idea of what to get. And they didn't have to obviously buy everything, but just something helpful to buy whatever they could, whatever kind of fats that they could find in the store, and the proteins that they would need, like if they could find tuna fish. There was an egg shortage here in Maryland, so that was something that they couldn't find at the time. But they were able to find frozen and some cans and some fresh fruits and vegetables. So this shopping list was sent to them as well, with instructions of how to pick up the stuff that we were giving them. Then we started the schedule. So on Monday morning, we started our first lecture via Zoom. It was attended by me and Dr. Kossoff. We did not have the child fast and ate a regular breakfast. And that was kind of like Dr. Kossoff's visit. Then we did our first Zoom lecture on my first Zoom lecture on how to weigh and measure foods. And we started her on a 2-to-1 with full calories. And if anybody knows the classical way that we do it, that we introduce the diet at Hopkins, we do half calories at a 4-to-1 for 24 hours and then full calories at a 4-to-1 for 24 hours. So this is a different way that we decided to do it. We didn't want to run into any issues of low blood sugars, of acidosis. So we kept her at full calories and starting her at a 2-to-1. Then at 3 o'clock, the doctor gave a class, which was Dr. Kossoff, on how to handle sicknesses, how to check ketones. And then after that class, I emailed all the 2-to-1 recipes. Oh, no, I'm sorry. That was in the morning. I'm sorry. I emailed all the 2-to-1 recipes for the lunch and for the dinner and then again for the breakfast. And I was available if the mom needed help preparing that meal. Then on day 2, on Tuesday, we just did a Zoom televisit in the morning. And then we always have a parent support group that comes in to give the parents some support that are already on the diet or have been on the diet. So they joined via Zoom. It was excellent. It really helped the mom because usually we have a large group starting the diet together and they could talk to each other, and she really had nobody, so this was great for her. Then at lunchtime, she was starting 4-to-1, and I had emailed her all the recipes for 4-to-1s to start at lunch. And after that, I taught her how to use the keto diet calculator. And then they were on their own to start a 4-to-1 classical keto diet. And this family, they were superstars. They did great. This is a picture of me teaching. A tuna salad meal. And for my next one, I'm going to videotape myself because I'm not handy like an Instagram user. Like I didn't know how to hold the camera, focus it on the salad, focus it on the tuna, focus it on the scale, focus it on everything and the paper. So next time I'm going to video myself doing it so I could be a little bit more prepared. And I'm on my kid's little, toy table, like trying to figure this all out. But it really worked out great, and the mom really got it. And then we met again on Wednesday just as a follow-up visit, making sure that they tolerated the 4-to-1, making sure she knew how to use the keto diet calculator as needed. In our plan protocol for this outpatient telehealth, Zoom, whatever you want to call it, setting up of the diet, if a family is completely formula fed, we could skip a bunch of the lectures. And then again, on day 4, we met with them again. So again, no more classes, just really making sure that everybody's okay. And now I'm going to pass it on to Stacy.
Good afternoon, everyone. I'm going to talk a little bit today about starting the modified Atkins diet, outpatient over telehealth. So we ended up closing most of our clinics at the end of March, and we were converting our scheduled patients to telehealth appointments. Initially, it was mostly telephone, pictures, and emails. Doximity, I believe, is one of the ones we use. And then we were able to switch over to a platform through our hospital that had video and audio. And the second picture here, it's a picture of actually one of our conference rooms, and it's large enough to allow for physical distancing. So we were able to conduct our telehealth visits in this room, separated, and on the left side you could see our waiting room, and then on the right we were able to pull up educational materials. So it ended up being a really good setup, and the patients did really well with it. So for the telehealth initial visits, we received several types of new patients. We have patients that are familiar in our practice that I'm seeing for the first time, the dietitian is seeing, and then sometimes we get patients that are new to our practice entirely, where the neurologist and the dietitian have not seen them before. So first, we obviously get a history, our neuro exam through the telehealth video, and then my nutrition exam. But one of the big interesting things that I've found from telehealth is that it is so helpful to view the patient and the surroundings and all the family interactions. You can observe the family, the siblings, kind of get an idea of who's able to cook in the house. Most of the time, I would say the visits were in the kitchen or in an office, and actually we had a few patients that pulled over in their car. So, but just an idea of how they live is kind of a window into their lives. So once we got their history and kind of figured out where we were going to go with the diet, I would then email them the handouts and links. And I would do this through the portal or an encrypted email. So one of the patients we started, if we had not been closed down and not doing elective admissions, this patient would have come to the hospital to do a classical ketogenic diet. But in this situation, the parents were willing to do a modified Atkins in the meantime with the option of possibly doing the classical later. So that's just an example of a new patient we saw and how we kind of went through the history and then decided to go with a modified Atkins. So once I've emailed them the instruction sheets, we would start reviewing. Mainly the big one starting with nutrition label reading. They do receive a handout, but I thought something that was really helpful was to have them go to their kitchen and grab an item that they like to eat. If they're old enough, they can do it themselves, or the parent can go grab some different items, and then we can use that label to start reading labels and learning about subtracting fiber and counting the carbs throughout the day. And sometimes we were able to discuss different food items that would be diet appropriate, and they were able to pull them out, and we were able to determine what a serving carb would be for that food. Something else that was really helpful was engaging with tech-savvy patients. We have teenagers that come to clinic and they do not say much. Their parents are in control, doing most of the visit, and they're kind of in the background. During telehealth, I've seen more interaction, more personality from some of our patients because they're in front of the computer, they're kind of running the show, the parents kind of in the background, they're really interested. Just super helpful in getting them engaged. We had a 15-year-old that was actually with Javon syndrome that we saw, and she didn't say anything, the neurologist said in the office, but she was completely engaged during the telehealth visit. So she was able to do most of her diet instruction herself and figure out how she was going to follow the diet. So after we kind of complete this visit, we do send instructions with their carb allotment, some recommended supplements, fluid goals, et cetera, and then any links that we may have discussed during the initial visit. So for our follow-up visits, I do prepare them ahead of time to please have a weight and a height if possible. They can take a picture of the scale, or if they've been to an appointment recently, to make sure to have a weight. If they can send pictures of the urine ketone testing strips if we're using that and trying to monitor. And also sometimes I'll have them email me a food record, or we can verbally review it over the next follow-up visit. We usually see the patients, we try to see them about a month after, and then we kind of spread them out for modified Atkins. So we're always reviewing the understanding of the diet, going through the different foods to make sure they're counting the carbs correctly, and also things that they could substitute, finding the foods that they need during this time. We do still send them out for labs, for baseline lab work, and occasionally, in some instances, we will do blood ketones, the beta-hydroxybutyrate as well, to check on their progress. And we definitely try to make sure that the products they're using are falling into their carb counting for the day. So we do review some tips and discuss obstacles. Some of the obstacles we found during COVID-19 are decreased shopping trips, so they may be running out of some of their foods. So we try to discuss foods that have longer shelf lives that can be stored easily so they don't run out of their carb-friendly foods. Also, a lot of these kids are very bored. They're homeschooled, they're wanting to eat more because they're home, and they want to snack a lot. So we have to discuss behavior strategies sometimes, talk about still exercising or having activity, and also drinking plenty of water. So that's one of the other obstacles. But having a schedule and and sticking to their meals, especially the meals that they really like, is very helpful. So this kind of in a snapshot of how we were doing the modified Atkins, and so far it's been really successful, and especially for the teenage kids and the tech-savvy kids, we even feel like we may incorporate this regularly in the future because they were so engaged. So now I'm going to turn it over to I believe Robin.
Hi, everyone. Thanks again for being here today. It's been a real pleasure to be able to be here with you and kick off Keto University 2020 in this way. So glad that you're here. For today, these are my disclosures. And I would like to talk to you today about how to set up boundaries and expectations in the post-peak pandemic time. I know there's a lot of changes that are going on in staffing these days. I know that there are some dietitians that are now on a tray line when they used to be on the clinical floors in the hospital, as opposed to taking unpaid time. Or maybe you're a dietitian that has mostly been on the pediatric side of your hospital, and now you're having to cover some of the adult care side. Or you can be like me, and you're experiencing a rolling furlough in your department. So, if wherever you're at in all of these things, if you're feeling like me, then you are not feeling like you are there for your team in the full way that you used to be. You're not there for your team, and you're feeling like you're not there for your patients and your families. And when patients and families and the rest of your team are also feeling in that same way, it can cause a lot of insecurity, maybe some anxiety. And we all know that when you respond with a lot of anxiety, that you're not your best self. So I want to talk to you about what we are doing at my institution, and that is our rolling furloughs that we're doing in our department. So what we basically did was take the entire nutrition department and divide them into 4 different groups. So each group then was going to take an unpaid furlough for 1 week. And when we found out this information, my team, who is Wes Lohman, my fellow keto dietitian, whose picture there is in the slide, the back of his head. So Wes and I, we sent an email to our team with a few things of information so that we can kind of calm down the anxiety of, what to expect from the keto dietitians that may or may not be there from day to day. One of the things that we talked about was to attempt to avoid the back-to-back weeks of furlough. So if it was possible for us to take, like Wes would take a week for his furlough, and then the next week would be a week where both of us were available together, and then the next week would be me. That way it's not 2 full weeks where they just had one of their keto dietitians, that it would just be a week at a time. And we've been able to do this for this month of May, and I am currently in my furlough week right now. But so far it's working out well, and these weeks go by very quickly. One of the other things that we put in an email to our team was we would cover each other's keto clinic times. So Wes does a clinic 1 day a week, and I also do the same. So for the week where one of us would be gone, we would cover the other's clinic. And this was mainly because, whether that be a telemedicine visit or in person, which we're not doing at this time, but the nurse practitioners who run our clinic are still having clinics. They are not furloughed. They are taking pay cuts instead. So we wanted to make sure that those clinic times remained instead of being canceled completely. So we're just covering each other's clinics at this time. And also one of the other things that we thought would be important is to have a really strict inpatient admission schedule. And that means that when one of us is on furlough, we would not schedule an inpatient admission initiation during that time. It would only be on the weeks where both of us were available. And so far, we have had one inpatient initiation last week, and that went really well. They've actually amped up our hospital to take all of our elective admissions back in so we can get those going again, and that it went really well for that patient. So I also think that the schedule has been helpful to put in an email and give it to our team. We have done a handful of home starts. And I think the ones that we have done, at least a couple of them, probably would have been ones that we would have done at home anyway. In one case, there was one patient that was from out of state, so and an adult, so we probably would have done that for that patient anyway. Another one was a really fragile patient who was on palliative care, and we probably would have kept that patient home also. Probably half and half, that we've done on home starts were ones that maybe we would have already considered doing them a home start anyway. So I feel like it's important to be transparent, not only with your team, but with your patients and families. So if you were to email me right now, you would see that I have an out-of-office bounce back email that says who to contact and what phone number or what email you can go to. And I think this is pretty standard information, but at least it gives a sense of security to those that would try and find me somehow, either by phone or email or the EMR. All of these have bounce back kind of things to say, you know what, I'm not here, but here's who you can contact, and that person be available and know what's going on. Also, maybe giving your patients and families more access to Keto Diet Calculator would also be helpful. I know some facilities kind of lock this down a little bit so that they have more control over it. But maybe this is a time where you think about opening those things back up to families and giving them a little more responsibility there so that you can have your time available to do something else instead of kind of monitor the Keto Diet Calculator right now. So I would encourage you to play offense and not defense when it comes to communicating with your team and your families. Be transparent with them about what to expect from you during this time, and really sit down and take time to make a plan for what works for you and your clinic and your situation. And then do not waver from that plan. Stick to your plan and you will be successful.
Oh, sorry about that. We do have some questions that have already come in, and we can start taking those while we are waiting for Lindsay to join us. And you guys can feel free to put some questions in on the bottom right-hand screen in the Q&A box. I think this first question was geared specifically towards the Harvest talk, but I think all of you can feel free to answer it. This question is asking, what additional challenges did you all face in initiating the ketogenic diet as an outpatient, and how did you address them?
So my main, I would just say that it took a lot more work than a regular admission, and a lot more work. First of all, I converted all the recipes from a 2-to-1 to a 4-to-1, in a less than a 24-hour period, and that took a lot of time. I just didn't have everything available for me. So I really had to go on the fly with, like, again, that's what I was saying, like just preparing a meal for them, how to teach the meal. I didn't know how to show the camera the right way and all that. I'm also at home with my children, so that was a huge issue as well, trying to not have them and join me in my classes, which at some point one child always showed up. But I would just say it was a lot of extra time preparing for it. I will be very honest, Monday night before, I wanted all the 4-to-1 recipes, and I give my family a lot of recipes. So I was up very late at night, Monday night, preparing all those recipes so they could be ready. The mom was constantly emailing me appropriate questions, but still, it was just a lot of information in a 2-day period. So those were huge. It was just a lot of extra work, I would say.
Okay, and a follow-up question with that, Zahava, is about how many hours do you think it took for this outpatient initiation between Dr. Kossoff, you, and the nurse? How many hours each for that week would it take?
So actual class time, like Dr. Kossoff did, let's say, half hour in the morning and then gave an hour class in the afternoon. And I gave, let's say, I was in on the half-hour class in the morning and then 2 one-hour classes on Monday and then let's say 2 one-hour classes on Tuesday in theory. And that was actual Zoom time. And then we built in other times in case she needed more time. So this family was excellent, but it could be, another hour or 2 of classes might be needed. But for this patient, and then again on Wednesday was another half hour of like a clinic visit. So I didn't add that up in my head, but that's how much time Zoom was. And then in between that is all the preparation for the next class.
Can you hear me?
Mm-hmm. Yeah.
So I can add on to that. At our hospital, we, for 15 years, we've been doing outpatient initiations. And now with the current circumstance, the only difference has been the initial education that we provide that we have not been able to provide face-to-face. So that has typically an outpatient initiation in terms of time for the dietitian is usually about 5 hours of work time. Now add on to it another 2 hours with the actual education telehealth visit for brand new patients when we're starting them as outpatients. So on average, I would say it now with the addition of the telehealth education visit is an extra 2 hours. But other than that, we've always been doing the outpatient initiation slow, but gradual start. So.
And then do you have any nurses or anything, Vanessa, that work in your clinic that have additional time on?
Not yet. If they do, they usually take care of the following weeks during initiation. So we usually take to get them to goal, it is more of a little slower than what Zahava's team was sharing with us. And that's just to prevent any of the hypoglycemic and side effects. And so usually the nurse and doctor will follow up with them during the week. So we don't have a nurse that participates right at the beginning. It is solely the dietitian that participates and has that contact with the family during initiation. So the nurse might talk to them about prescriptions or making sure that they have doctors, their lab work or prescription information. But most of the questions are followed up through the dietitian.
Okay, thank you.
You're welcome.
We are going to try to go to Lindsay and see if she is available. Lindsay?
Yes, we see the pitfalls of telehealth here. Computer crashes. Okay, so I'm not sure what slide Ellen's on, but I have a disclosure slide, and then I'm going to talk to you guys about virtual diet initiations using Microsoft Teams. So I was able to hear the others talking, so I won't kind of repeat what other people have said, but this is just one example of how you can initiate the diet, what was traditionally an inpatient initiation for about 90% of our patients. We converted that to a virtual process, so not just an outpatient process, but also virtually. And so I broke it up into 5 kind of steps that the patients go through. So step 1 is that the patient's primary neurology provider refers the patient to our screening clinic. And this is an unchanged process from before the COVID pandemic. Step 2 is our keto screening clinic visit, and this is for new diet referrals. So we do a visit where we make sure they have all their screening labs. We provide education. I'll provide a little more detail on the next slide with that one. Step 3 is our pre-diet visit, and this is just right before we actually put them on a ketogenic ratio. We go through just a kind of a checklist, make sure they have all the supplies they need. They're ready to go when we give them those first recipes that are actually keto. Step 4 is our titration appointments, and those are most often weekly, but we might go a little longer than that, and those are when we're actively initiating the patient up. And then follow-up is once the patient is in an adequate level of ketosis, we refer them back to their primary neurology provider. So what we changed about our process is that we have a designated nurse practitioner and a designated dietitian that follow them from step 2 to 4, and that may not be their primary neurology provider. So we really wanted to limit who was doing these because there was so much variability, and so we have identified a single nurse practitioner that would take care of each patient throughout those steps. So I'll just go into a little bit of detail with each of these steps, knowing that we only have a few minutes left. But so step 2 is our screening clinic visit. So this, prior to going virtual, we did this in a multidisciplinary clinic where we would have a group of patients come and we would do an education PowerPoint, and then we would break them up into separate clinic rooms. What we're doing now is a multidisciplinary visit via Teams. So what happens is the patient and the nurse practitioner log on to Teams first, and they go through a PowerPoint of just the diet basics, side effects, risks, what to expect, and then they do a medical evaluation just to make sure, they know that their medications will need converted and things like that. And then once the nurse practitioner is done, they chat us via the chat function in Teams. And the nutrition team logs on. And so then we complete our nutrition assessment. I know Stacy pointed out making sure that the family has the ability to weigh their patient at home. So you may need to send something in advance to explain to them how to do that at home if they need to. And then kind of towards the end of this visit, if we know they're going to be moving forward with keto, we go ahead and provide them with some education materials to go ahead and kind of start getting their diets moving more towards keto. So we provide them with the Charlie Foundation Whole Foods diet handout. We might provide them with like a fluid goal, some other goals to work on, a supply list, just so they can kind of get going with that. And then we want to think about formula, and if we need to start calling insurance companies and making sure that a ketogenic formula would be covered, establishing a DME might be something that needs to happen. So step 3 is the next step. So if the patient is going to move forward with the diet, we do a pre-diet visit, and this can be either via Teams, or for some patients it could be just like a portal message. If they're pretty on it and you feel like you kind of know they have everything ready to go, it may not need to be a full Teams visit, but for other families they may need to have another face-to-face, just kind of chat about what will be happening next. And so what we do with this, prior to COVID, this was just a phone call we made right before the initiation. And so it was just kind of a checklist that they have everything they need. So we want to make sure they have all their medications converted to the lowest carbohydrate form, so we don't want to be dealing with that after we've started initiating the diet. We want to make sure they have urine ketone sticks, their gram scale, any food they're going to need, because obviously during this time it may take a little bit more time to obtain food, formula and supplies. And with this, you may need to consider, typically we're going to be advancing and titrating their diet in an inpatient unit with the formula. So you may need to work with your formula, the company that makes your formula, see if they can provide some samples for kind of that in-between period before you're on kind of their final formula recipe. But as you're titrating up, you could also work with their DME company and see if they would, for a month provide kind of half and half their old formula and new formula until you figure out kind of where they're going to settle out. And then just discussing with the family home weights and at what frequency those will be recommended so they either can get a scale or you have a plan for how that's going to happen. And then step 4, this is the last one I'll discuss because it's the main thing we changed when going from being at the hospital to virtual. So we schedule the titration appointments weekly, but some families may need some longer time between to adjust. And then we're typically advancing the ratio by 0.5 to 1 to 1 each week. So starting at a 1-to-1 ratio and then each week going up a little bit. So at each of these visits, we check on diet tolerance, we check on seizure control, where their urine ketones are. In terms of monitoring, we're only monitoring urine ketones at home. We just kind of chose that one because it's easy to get the urine ketone sticks. There's not a lot of explaining necessary. There's not a lot of equipment needed. So that's not necessarily the right option for everyone. You might want to use the blood ketone monitors if that's what you're already doing in your center, but that was just what we chose, even though it's not always perfect with all patients. We do want to limit them coming back into the hospital, so we're trying to avoid getting blood draws at the hospital if possible, but if they are symptomatic, we are sending them to get labs drawn. And then at each of these titration visits, we're providing some sort of diet education initially, showing them how to use a gram scale, obviously, and then as we kind of go through the weeks, providing more and more of the medical education and kind of how you're going to apply this long-term and things like that. So that's kind of a summary of how we've converted from hospital-based ketogenic diet to teams. And again, I apologize for the technical difficulties, and I'm happy to participate in the Q&A now.
Fantastic. Thank you, Lindsay, for sharing that with us. And thank you to the rest of our ambassadors for all of your presentations. We do have some more questions that have come in, and we will not, for those of you who do need to drop off in the next 4 minutes, I completely understand, but I do want to get through as many of these questions as we can, and for anybody who can stay on longer, that would be wonderful. I will continue on with our questions, but just so everybody is aware, our next Keto University, the live event will be June 12th through 14th in Portland, Oregon. And we are announcing registration by the end of 2020 for our U.S. and Canadian participants. We are going to be hopefully having our live event that we couldn't do this year, next year in Portland. And for our next webinar, it will be Wednesday, May 27th is the next Keto University virtual webinar that we are doing. So thank you to our Keto ambassadors for participating in this virtual Keto U, and thank you to all of you who are attending. If you are unable to stay for the rest of our Q&A, we have a QR code for the SurveyMonkey where you can complete the survey via the link on the screen or a pop-up window whenever you close down this session, and that will get you your certificate of attendance that you can use for your continuing education if you need those credits in the United States, or contact your Nutricia rep if you are outside of the United States. For the rest of our questions, which aspects of virtual diet initiation, do you think that you guys, or not even virtual diet initiation, but new ways of working that you guys have started implementing, do you think you guys will carry over post-COVID times? Have you guys talked about this within your clinic? Have you guys found new ways of working that you think you'll carry over after all of this is said and done?
I guess I can answer that. This is Lindsay. When we kind of knew this was all happening, we did discuss that as a group, that we should come up with a process that was sustainable beyond this, not knowing how long it would last. So I know at our hospital, they're only planning on ramping up to a maximum of 60% live clinic visits that they were doing prior to the pandemic for the foreseeable future. So we do plan on continuing that. We've also implemented some huddles via Teams, using Teams, where we come together and discuss the workload and discuss the day, and that's really streamlined our processes, and we'll continue to do that even if more people are back at the hospital.
Have the rest of you talked about it in your clinics, or no?
This is Ahava. We have not discussed it at all. I can't imagine that we would continue doing this. However, what we are learning from this is just how nice it is to actually see the foods and see actually what they are eating prior and during, like any questions she had, she could show me her pantry. There's something very nice to see a child in their own environment versus in the hospital. But in reality, I doubt it, but we have not discussed it.
So we did not have any kind of telemedicine, telehealth prior to the pandemic. So I'm hoping that we'll be able to maintain those visits, at least most of them somehow. I feel like I think a barrier to some of our families is actually getting into Chicago. If they are not living in the city, they're living in the outskirts somewhere, and driving into the city is pretty stressful. Also, if you are in a giant vehicle, because you have to have your whole family, or you have to house like a wheelchair or something in there, finding parking can be really difficult. And then you have to carry all of your gear with you into the hospital also. And we know how hard that is for some of our families, especially if we're going to see them for like 15 or 20 minutes. It seems like such a short amount of time for a really stressful day for them. And so I really hope that we'll be able to continue using some of this telehealth, because this is brand new in our facility.
Thank you, guys. This question is for all of you. The person who wrote this question works with low-income families and isn't really sure if the ketogenic diet will work for them. So I know that you guys work with a variety of different families. So how do you all deal with different socioeconomic levels of families?
Well, this is Vanessa, and one of the things that has helped me with families, not just in keto diet, but also with diabetes, is doing a food frequency questionnaire, maybe trying to adhere to the ketogenic diet as close as possible to foods that they've already consumed. And whereas, we know that the cost of a lot of high-fat foods like eggs and protein foods and butter can be very expensive, but using things that they may already have. So if they're using, for example, bacon, using such things as the bacon grease, as part of their diet. Any which way in terms of how you can make that diet possible. Sometimes it is limiting that the recipes that they may be able to provide may be limiting, but if it means that this is the only way that the child can have success on the diet, then sometimes just limiting those recipe options to the foods that they can afford has really helped my patients that are considered low income or have a hard time with these very more expensive foods.
Hi, this is Stacy. I just want to share with Modified Atkins, as well as some of the keto patients, but mainly Modified Atkins. There are a lot of school districts that provide, at least in Florida, provide breakfast and lunch. And if you can get in touch with those cafeterias or the county dietitians, often you can get the menus from them, and they are able to help form different meal plans for the patient, so they have a choice, but also that they can stay in their carb allotment and get their breakfast and lunch. And I think that's been really, really helpful in having them stick to the diet and also get 2 nutritious meals, whereas at home it may not be as plentiful. So that's been really helpful.
Thank you, too. How do you, I feel like this happens all the time in many meetings and everything, just in general. How do you all deal with families who multitask during their appointments? I feel like we're all running and being pulled in multiple different areas. What about when you're educating a family for the ketogenic diet? How do you deal with a family who just isn't completely paying attention 100%?
Ooh, this is Vanessa again, because I've encountered that a few times, and I think you need to be very clear about the expectations from your patient beforehand. Have them find a quiet place, have them be ready, letting them know how long the visit is going to take, and when you do call them or they log on to the call, ensure that is this still a good time to do the visit? If not, you giving them the option to reschedule, or maybe you have the option of calling them later. But I've had patients where they're on the call on their cell phone and they're going through the whole entire house doing tasks, laundry, cooking, and the whole entire time the angle of their camera is like up their chin and their nose, and it's very hard to really communicate because it's constant. Oh, what were you saying? I didn't hear you. Can you repeat that? And it actually makes both parties frustrated, and it makes it a longer visit. So setting up those expectations ahead of time, making sure that your patient as well as you have very little distractions, and during your consent that they are doing that telehealth visit, making it clear that is this still a good time really helps.
I think too, this is Lindsay, given this is such a unique situation and many families don't have any backup right now for childcare. So breaking it down into maybe smaller visits with many fewer objectives for your for each of your educations that you're providing, and maybe it does take more frequency. And then also, I think it's important to highlight the use of teach back. So asking them what they understand from what you said, and having them actually repeat it to you what they understood. So then you can keep notes and say, okay, I planned to get through all of this, but they clearly only took objective 1 and 2 that we were of the 10 that we were planning to go over today. So then the next time you meet with them, you can readdress the ones that they clearly didn't take. because it's just such a unique time right now, and whereas most of the time people might have grandparents or somebody to help them, they may not have that right now, so you also kind of have to meet them where they're at.
Great. And we've got a couple more questions, and this one, these next two questions center around lab work. Zahava and Lindsay, I know both of you guys are doing home starts. Do you guys get lab work for patients prior to starting doing the home initiations?
Hi, this is Zahava.
Yeah.
So we did not get lab work on this current patient, but we are doing it patient by patient. This patient had, I should reframe that. This patient just had lab work done 3 months ago because they were going on the diet like back then. So we did lab work then. They were all normal. Nothing changed. So we did not do lab work on this patient, but I think it depends on what kind of patient we'll be seeing next.
Yeah, so I would say we do get some sort of initial lab work. If it was recently, like within the last 3 months, it would probably be good enough. But we definitely make sure we get all the screening labs to ensure it's safe to start the diet before.
Okay, and then the other question around lab work is monitoring blood sugar during initiation and after. I think, Lindsay, you kind of touched on this a little bit, but regularly monitoring blood sugar.
We are not doing that.
Continue, Lindsay.
We're not measuring blood sugars. We feel we're going slow enough that we do educate them on the symptoms of hypoglycemia, but we're not measuring it.
So same thing. I mean, we're going a little bit faster than with Lindsay, but we also are going a little bit slower than what we're used to. And we also did not check, but also taught about the signs.
Okay, and then I'm going to do one last question and then wrap it up. Have any of you done any group initiations or thought about doing any group initiations over video or telemedicine?
So, hi, it's Zahava again. So we considered it, and then I said, let's try it and with one patient at one time. And I can't imagine doing more than one patient unless it would just be for one education, like initial kind of class, and then slowly advance everybody separately. It was just a lot of work on my end to come up with all the recipes that fast. But if you go much slower, it can be easier, I guess, for some educations. But I'm happy that we did not do a group class.
Is anybody else, have you thought about doing a group class or tried any group classes?
No, we didn't do group classes prior to this, and it's never been on our radar to ever do. Even though we have 2 dietitians, we will do 2 initiations in the same week, but usually we're divided between the 2 so that we're only doing 1 each at a time.
Thank you, Robin. All right, so with that, in the interest of time, I do want to wrap it up and say thank you again to all of you for staying on the line with us and joining us for our first KetoU webinar. And again, we do have our survey. You can scan the QR code or go to the SurveyMonkey link on the slide there. It should also pop up in your browser as well. We do appreciate your feedback and do take it to heart. So we would love to hear from you guys and hear what you think about our webinar. And a thank you to all of our 5 Keto ambassadors for helping to kick off our first virtual Keto University. And thank you all for attending this wonderful event with us. As I said, our next Keto University webinar will be on Wednesday, May 27th. It will be the low and slow outpatient initiation of the ketogenic diet. So you guys can hear from Jennifer Fabe from Canada. She'll be teaching you all how she initiates patients in an outpatient setting, because in Canada, they cannot admit patients to start the classic ketogenic diet. So this has been something that she is used to doing. So join us for that webinar, and we will talk to you all then. Have a wonderful day and rest of your week. Thanks a lot for joining us. Bye.